For an autistic, when the environment fits your individual needs, you will thrive. Feel calm, balanced. You might prevent a lot of health issues if you can avoid stress. For autistics, an adjusted environment is very, very important. Choose to see the whole elephant. It's absolutely crucial in autism to see the potential for PTSD because of our special autistic neurobiology.
I'm Dr. Amitta Shah. I'm a consultant clinical psychologist and I'm chartered with the British Psychological Society. And my experience, I've been working in the field of autism for the last 32 years. And one of my mentors has been Dr. Lorna Wing, and I started my career with her.
I understand you've been doing a lot of work with Dr. Lorna Wing on catatonia. Can you tell us a bit more about that and how it manifests in people with autism?
Yes. Catatonia is a very poorly understood condition. They are saying, is this catatonia? A lot of psychiatrists, psychologists, neurologists who get to see this because they haven't heard about it or seen how it is manifested in people with autism. Draw the distinction between catatonic stupor, which people know about when people is in acute, they can't move at all. But when we see it in people with autism, it's often a much more, it develops very gradually, and we call it catatonia-like deterioration, because it's gradual and it is actually more difficult to diagnose than the acute stupor state. But it affects, it's a deterioration, a regression, and sometimes it's a shutdown of functioning. So people become dependent on external prompts to be able to do things. But it fluctuates, it can fluctuate from day to day, it can fluctuate from hour to hour. So some days the person is fine, can carry out a lot of smooth movements and activities and so on, and other days they may not be able to get out of bed, and they may not be able to speak, they may not be able to do anything that requires voluntary movement.
And what causes catatonia?
I think we might as well ask what causes autism, because we really don't know. But what we don't know at the level of the brain, but we do know that stress and anxiety are actually major factors which cause the catatonia-like deterioration in the majority of people. But it's stress at various levels. So it could be stress to do with not being in the right environment, not being in the right program, or it could be psychological stress. Sometimes it's a bereavement, sometimes it's the pressure of exams in the more higher functioning ones. Sometimes it's people who have had a breakdown at university because they haven't been able to cope with the demands of university, and they have developed catatonia-like deterioration. So I think we feel that stress and anxiety is a particularly big part of it.
And what have you found to be the most effective treatment for catatonia in people with autism?
We've developed what's called the Shah Wing approach, which is it's a non-medical approach to treating catatonia in people with autism, and it involves actually doing a very detailed assessment of the person and understanding what the person may be going through, in the environment or the program that they're in, and also advising the staff in managing the catatonia. So often, staff think that they're being lazy, they're being willful, they're stubborn, and they will leave a person in a frozen state or will not actually give them the prompts. And one of the basic things is that you have to give them external verbal prompts and sometimes even physical prompts to enable them to carry out smooth movements. And that in itself has good results on their overall catatonia.
If a parent, a carer or practitioner is concerned that it may be catatonia, who should they speak to and what should they do?
think they should raise it with their professional team. So they should certainly speak to their consultant psychiatrist and clinical psychologist. And I particularly find that clinical psychologists are very well placed to understand this condition, especially as we are advocating a non-medical approach. When you use a medical approach, it often actually makes the catatonia a lot more severe. I only recommend medication and ECT as very last resort treatments. But what Dr. Lorna Wing and I developed, what we call the Shah Wing approach, which is a non-medical approach to looking at catatonia and understanding it. So it's a very individual approach. It's holistic. It's not any particular treatment, but it's actually it's about becoming aware of catatonia early on, before in its early stages, and getting carers, staff, and other people to actually recognize it and do something about it at very early stages. So we have so there's various stages. So one of the things is, how do you support somebody who is catatonia? So that's part of the treatment. And then following on for that is, looking at the cause of catatonia, in a particular individual. Because if you look, a lot of our studies showed that there were particular stresses which people in trauma, which people had gone through, which were often responsible for triggering of the catatonia. And the stress can be very different for different individuals. So you need a detailed assessment and look at that, and then try and look at their environment, their program, their lifestyle, to see how you can cut down on the stress, and how you can also raise their threshold for tolerating stress and anxiety, because there is always going to be something that triggers off stress and anxiety. So we look at working at and this isn't about a particular psychological treatment. It's not that, okay, so we have somebody and we're going to give them 6 sessions of CBT. It's actually looking at what the person needs, and sometimes they may need input from the speech and language therapist. The OTs can devise programs which will be beneficial for them. Physiotherapists can help with the movement side of things, and psychologists particularly can look at can do good assessment as to their type of autism, their level of autism, how the autism affects them, and what are the likely stressors for this person, and then devise an individual plan of management. So that's what we recommend, this approach to treat and manage catatonia. So in people with autism, catatonia is a very interesting phenomenon, in the sense that a lot of features of catatonia actually are features of autism as well. So there is an overlap between the two conditions. But that's not the catatonia type deterioration, and that's not what needs the management. It's when these features become exacerbated, and when the catatonia actually increases. So what you may see, the early signs are that the person with autism will become slow in their movements. They might start hesitating. They might start speaking much slowly. They might not, and gradually they will not be able to get out of bed. They may not want to. They may want to, but they're not able to actually complete movements. And sometimes, if they start a movement, they're not able to stop a movement. So the early signs are, if you find that somebody is actually showing any deterioration, or if they start losing interest in the things that they've been doing before, if they start losing skills, or if they're not able to, if they start losing their independence, particularly, because they become very prompt dependent. So they can't carry out actions and activities unless somebody somebody gives them a prompt, and this can be a verbal prompt or sometimes a physical prompt, and then they can carry out activities and actions and so on. It's a very interesting question because, you know, historically, catatonia has been associated with schizophrenia, quite wrongly. So it was only, so if anybody showed any catatonia, they would also be given a label of a type of schizophrenia. But in people with autism, we don't often see the extreme form of catatonia. So what you actually see is this pattern of deterioration, and it can be quite subtle initially as well. So, you know, there may just be an increase in their repetitive movements. They may start showing a lot of complex rituals, those which they hadn't shown before, or an increase in the ones that they had been showing, and then gradually it affects more and more of their movements and their behavior. I think the other thing is that, you know, a lot of people with autism are not able to talk about what is happening to them. So that in itself complicates things, because we relate it to underlying stress, trauma, anxiety. And you know, people are not able to communicate there, and they slowly start shutting down. So there's various, in autism we see various forms of catatonia. So either you see the catatonic features, which are sometimes part of the autistic features, or they are an exacerbation, or you see shutdown, which can be either temporary shutdown in some situations, which is very anxiety provoking, or they get shut down for longer and longer periods, or they may have just you know, transient difficulties. On some days they're not able to function very well. They're not able to do the things that without having prompts. And in autism particularly, our studies showed that it's related to it's most frequently seen in people with autism who are more passive anyway. So people who are passive are actually less active, they're less spontaneous, they have difficulty initiating interaction and communication and so on. And these people seem to be more at risk of developing catatonia.
This is the book written by Dr. Amitta Shah, Catatonia, Shutdown and Breakdown in Autism, a psycho-ecological approach, where she describes exactly what catatonia is, and there are different case studies and so on.
So I first became interested a long time ago when I was an undergraduate at UCL doing my degree in psychology, and it was in the final year, and we only had one lecture on autism, and it was given by none other than Professor FREEZY. And I think the way her enthusiasm sparked off something in me, and I became interested in autism as I had never been on any other subject on the course. So I remember very distinctly that after the lecture, I ran up to her and I said, you know, could I follow up on this? I want more references. And she invited me to her office in the afternoon. And I haven't looked back since, really. So that was my first, you know, sort of interest in autism. And then I did my research in autism under FREEZY. And of course, I did all my other research and clinical work under the guidance of Dr. Lorna Wing. So I really had two of the best people in the world as my mentors. Currently, I work as an independent consultant psychologist, and I've always been interested in the secondary difficulties of autism. So I've done a lot of work in initial diagnosis. I used to work at the Lorna Wing Center using the DISCO, but my work has been with more complex difficulties. So I've worked with challenging behavior with people with autism who have a breakdown either in behavior or in mental health. And that's what really got me interested in catatonia. So a lot of my work at the moment is raising awareness of catatonia, doing a lot of training so that people become aware and pick it up early and know what to do when somebody develops catatonia, because it can be such a devastating condition. And I'm now, as we speak, I'm actually looking to see, how, where we can link in with in the NHS, because it's still not, because the professionals are still not picking it up. In fact, to the point of where, if families are going with, because they've heard about it or they've seen a video or something and they are saying, is this catatonia? A lot of psychiatrists, psychologists, neurologists who get to see this because they haven't heard about it or seen how it is manifested in people with autism. So so my work at the moment has all become focused on catatonia. In terms of treatment, whenever there is a condition, people always try the medical treatments, and in the past, catatonia, it has been, people have followed a medical model and they have tried, and it's a trial and error. There isn't any tried and tested medication. There are case reports of particular medications that people have tried, but it's usually when the catatonia is very severe, because it can become life-threatening at that stage as well, and you have to try anything.
In Dr. Amitta Shah's book, she describes practically in every single case how stress and anxiety are the triggers for shutdown and then catatonia. But then there are always signs of distress before it. Breakdown. Some individuals show additional difficulties characteristic of autism breakdown. This may include an overall exacerbation of their autism. For example, increased social and communication difficulties, and increased repetitive activities and rituals. Because you try to regulate, right? When you feel anxious, when you feel stressed, then you do things that calm you down. In some individuals, the breakdown decreases their level of concentration, focus, engagement, and enjoyment. In some individuals, their tolerance for others' demands decreases, and they start showing a pattern of demand resistance characteristics. That's also very logical. If you feel stressed, then everything is too much, and then a demand that usually does not cause stress, in that state of distress, will be too much, and it can push you over the edge. The so-called last straw that breaks the camel's back.
Important, so important that we recognize that behavior as burnout, exhaustion, struggle, lacking the ability to communicate. That behavior is communication. It can look like a number of things, but also it can look like trauma. That our brains are structured in a very similar way to a brain that has experienced significant trauma. And there's a very fine line between pushing beyond our natural limits to do something that we want to engage with and tipping ourselves over into trauma. Very well see escalated anxiety, aggressive behaviour, changes in their eating, sleeping, toileting, all of those things.
And then this happens. Effects on speech. It can affect speech content, fluency and volume. Often someone who has been able to speak fluently and communicate well starts talking in a whisper or hesitates a lot, which appears like a stutter, or generally talks and communicates a lot less than previously. Speech difficulties can progress to severe levels until the person becomes mute, either all the time or in certain situations.
Lacking the ability to communicate.
To me, this is very familiar. Speech directly being impaired by your level of stress.
For you to know is that a lot of these children who are diagnosed as autistic, their problem is not really in the reception of language. In other words, they understand the language that's being spoken around them. Their problem is in the expression of it.
We also tap into senses that other people can't see or may not be aware of. So energy is the first language. It's our native tongue for autistic people. Verbal communication is not our native tongue, it's energy, what we feel about other people.
And because of that, they need to have someone assist them in learning how to manipulate their organs that are used in expression. And this area that's in blue, Broca's area, is the part of the brain that's involved in the motor expression of language, and that's oftentimes the area of the brain that's affected in these kids, and it gets affected during development. And so they have come up with various tools, such as laptops, that have helped these children to finally communicate.
It's really important to understand that there's a distinct difference in a person or a child's conscious thinking and their neurobiological response. So remembering that that neurobiological response does not give a damn about details. It doesn't know what your wants and desires are. It's just purely primal, animal. That's our animal brain. So it goes, we need to survive. Our conscious thinking is about what do we want and need, and what are our emotional responses. This here, the neurobiological process, just goes, what information are we getting from our senses, and how much of that is a threat, how much of it is safe. Have a distinct neurobiology. We're autistic people, but we also have an overactive threat response. Live a lot of your life in fight, flight, freeze, or fawn. Often, I'm a very relaxed person in my own environment. However, I check in regularly with my body and it's always tense. It's always tensed up. And that is fight, flight, freeze, or fawn. That's the threat response. So even when my mind is completely relaxed, the neurobiology still is overactive and still tenses up my body ready to do whatever I need to do to get the hell out of there.
My somatic experience practitioner trained also under Steve Hoskinson, who is the founder of Organic Intelligence.
You see this dorsovagal term here, and the dorsovagal term, that references Stephen Porges' polyvagal theory. When we were back in the day saying, oh, stress is the brake and the accelerator on at the same time, the brake was the parasympathetic branch, and people would remember it by parachute, bringing you down and so on, and rest and digest and so on. But it's more than that. And so Porges' contribution was nice because it says, it's not one system, but at least two. The parasympathetic has two major branches that are different, and they're different phylogenetically, they're different architecturally, and they're different functionally, which means they're different in terms of their evolutionary history, which is where Porges traced it. They're different in the nerves and the way they're operating. For instance, the ventral or the engagement system is more myelinated, and the dorsal system is not as myelinated. And then it's different functionally. So these two branches are functionally quite different. The dorsal vagal process, Porges traced way back to cartilaginous fish. And remember when I was going, oh, the paramecium's moving around, it's locomotion that goes, eh! The most primitive self-protective response is don't move. Like, stop your locomotion, because predators often need motion to stimulate their predatory approach. So if I can just go, eh! Then I'm not so much a target. But it goes all the way back then to cartilaginous fish. So if you've seen like National Geographic, you're seeing deep under the sea, and then these wild creatures, you know, just going by, and then they come out again. All of that FREEZY business is older than bones. FREEZY business is older than bones. And so that's old. That's pretty old. No, it's old, and so it's more primitive. So that's the phylogenetic piece. That's its evolutionary piece. Architecturally, in terms of how it's operating, it is innervating primarily subdiaphragmatically, the organs, the visceral system, and it is mostly feeding back information that's important for homeostasis. So it's sussing out, hey, how things going in the most vital regions here, organ system, right? And so it's giving back that information, and then functionally, it is really good at freezing. I mean, it's always involved in things like peristalsis and so on, but but it is also this freezing system, or the system. And wow, that's an oxygen conservation system. So you slow down the heart rate, you slow down the need for oxygen, you slow down the metabolic process, and the system can operate in a hypoxic state more readily. You hear every now and then, the kiddos falling through the ice, they've been under there 15, 30 minutes, and with careful sort of resuscitation, they can actually be okay without like significant brain damage. That always mystifies people till you get like, oh yeah, this freeze system starts to shut down oxygen using systems and just preserves that brain. So it's going to shut down, it's going to slow down this oxygen using process, and giving you a chance to, get rescued and get oxygen back to the brain. It's super amazing and super problematic when it is ongoing and not resolved. So I guess moving on then to our work with it, freeze has important psychological and behavioral and sort of components, such that for us, freeze means, and there's a whole continuum of freeze. Have we done the dissociative continuum yet? We could do that. We could do that for sure. And there's a whole range of how freeze is going to manifest. Everything from an out-of-body experience or catatonia to like, I dinged my little pinky and there's a little bit of numbness there. So it can be this really micro expression of it all the way to this, massive systemic shutdown. And then as we experience it, it's going to be a diminution of, or a decrease of affective range, affective modulation that includes prosody, like the voice and the way that we are singing. You know, if you ever listen to a mom or a parent with a baby, they're singing to those babies, and that prosody prosody is this ventral vagal thing, as opposed to the flattened affect and the breathy voice and the pitch not modulating like that. We had a flight attendant, a guy who was talking like something like this onto his thing. It's like, you know, that you're immediately hearing that's FREEZY business impinged on his system. So the prosody is the modulation of pitch. That's a part of the system. So when you're think depression and somebody not having the energy, and also like the ventral vagal system innervates the facial muscles. So all of like baby communication, when you know, and communication with lovers and friends, you know, there's all of this like emotional signaling that's nuanced as all get out. We're talking about orientation and connecting to the environment through the senses. When Phil was saying, oh, you know, there are people out there, he was orienting. His system was orienting social engagement, and that's prototypical ventral vagal process. So part of the reason that we are so keen on orientation is that it primes for that ventral vagal system, which shows up in its prototypical form as social engagement. But for us, because our attachment history has been so compromised and is so impoverished, like people and tribe is sketchy. So I'm pretty ambivalent about other people, and you know, and so for good reason. But it means that we use the ventral vagal impulse and architecture in a free-form way by saying, oh, what if you just let your eyes go where they want to go? And then you leave it up to the organism to choose what it's going to find as the target of its ventral vagal search. And a lot of times it'll find nature. And sometimes you will be with a person who's really sort of dialed in, and you know, and they'll just look at you, going, my eyes are going, you know, where they want to go, right? And so, and then there is like there is freeze face, right? Like flattened affect, not much mobility, not much movement of pitch. So, which, by the way, has really, like, all of that signaling is what feeds baby brains. That grows dendrites in baby brains, really important. And if you Botox that away, the baby's like, what happened to mom? You know, who put Frankenstein up here? The zombie movies, I ain't ready for that. So that's important. That social engagement signaling is what helps us understand tribe and how you're doing. I get an instant snapshot of your entire system just by seeing how things are there, right? So, and Porges' contribution to our understanding of the autonomic nervous system is that, like back in the day, we would say, oh, stress, that means you have the accelerator and the brake on at the same time. And the accelerator is sympathetic arousal. And remember, sympathetic arousal isn't just fight or flight. When we're talking about sympathetic arousal and this curve here, this is just the acceleration of high intensity on sympathetic arousal. You have whole ranges that aren't pictured down here that are just the easy metabolic function and contribution of that energy system into our biology. So when we're talking about sympathetic arousal in this range, we're just talking about the higher intensity zones, especially those that are pertaining to the survival responses of fight and flight. That's the highest intensity of sympathetic arousal. And just as a little extra nerdy information, in terms of fight and flight and even a freeze, there are areas in the brainstem and the periaqueductal gray that are localized for those kinds of behaviors and organizing those kinds of behaviors. So even though it is fueled by sympathetic arousal, it still has these distinct sort of pathways, say, for fight and flight. That's why we can say sympathetic arousal isn't just fight or flight, or it's not one general energy system. It's also really quite refined. So the resolution of that and the completion of that, the movement of thresholds up through that, and my comfort in that is handled by the fact that in freeze there is just as much blue as red, right? Every stick has two ends, and so in this graph here, you see this is the freezy business. Things are fragmented, they're kind of broken apart, they are dissociated, but it has just as much blue as red. So I'm not afraid of freeze. There is plenty of mojo and exceeding mojo in these states, because with less emotion, with less sensation, with less sort of input from the outside, I can have less of a discrete experience of myself and of borders and boundaries. Like if I don't feel where I begin and end, suddenly I can receive and perceive things that are outside of myself, and in fact, I'm not even sure where outside of myself might be. Some of us think this experience of oneness and non-self, for instance, is a really important step. You get a taste of that from being in freeze. And a blue side of that is I don't have the narrow conditioning input from my physiology that actually begins to let's hold the mic for just a second, because I have a queue of people who are asking questions. So my sense of self is important to build, but it's basically built around I like it, I don't like it, the approach avoidance system, what's red and what's blue. I'm a person who likes sashimi. I'm a person who really enjoys ramen. I'm a person who is a mover, I like movement, and there are certain things that I don't like, and, like scratchy t-shirts or something, right? I mean, there's a whole, that's me. But if you ask somebody in this state, oh, do you like t-shirts that are maybe more, maybe not bamboo or soft cotton or stuff, it's like, I don't know. Do you want to go see a movie? Yeah, I don't know. It's like, yeah, what do you want to see? I don't know. What do you want to see? I don't know. What do you want to see? And so it's undifferentiated. I'm not sure. What do you like? What do you think I should like? I'm not sure. I don't have my reds and blues identified. I'm undifferentiated. Right? So part of what we're trying to do is help them differentiate by going, okay, yeah, would it be better for you to would it sit or stand? You want to talk, not talk. You want to sit over here, over there. You want the blinds up or blinds down? Do you like this? Do you not like this? Do you like that? Do you not like that? And all of that is beginning to identify and create self. And that's, for people that are in the whole non-dual thing, that's a problem. It's like, hey, wait a minute, aren't we trying to get that? You can't transcend self till you got one. And so we're trying to build then ego strengthening by building that sense of, hey, I'm this. I like this. I don't like that. And my reds and blues and the clearer differentiation, definition of those creates a sense of where and how I am in terms of emotional and cognitive definition, and then hopefully also a bit of the sensation that goes with that. This is me. That's ego strength. And to be able to get feedback of like, oh, now I'm choosing to take this action, and I can actually have a thought, oh, now I'm going to take this action and follow through with that and get feedback on it. That reinforces this agency that says, I can do this, I can. And the first word of that is I. Like, I have capacity, I have agency, I can act on the world, and the world gives me feedback that I just did that. As opposed to Botox face, right? Botox face is no response. And that's where I don't exist because what I do gets no feedback. So feedback is key, and that builds back ego strengthening that then we can take into, say, a freezy state, and then all of that can dissolve. All of that can let go. And again, part of the reason that Jack Kornfield and others had me talk to their teachers is because people get into freezy states and they begin to disappear, but without the ego strength to say, ah, yes, now I feel released from self, rather than I'm fragmenting and I don't know where I am. That's the red side is I am disappearing, I'm going where, and the blue side is I'm released from this conditioning, and I feel the participation with everything that is without distinction. So that's a pretty big blue, right? And the unhooking of the reds from that blue is really key, so we can just get that state of dorsal vagal. So, but it's that, to me, the end game is biological synchrony, which means all of these states are working in concert. That is, I've got access to my freeziness, I've got access to those states and all the benefits of those states, I've got access to sympathetic arousal, and the freezy business is oneness, non-identification, non-attachment, and sort of emotional neutrality, or on the red side, flatness. And then on the sympathetic side, sympathetic is really good at the honing of attention. So I have singleness. So at the same time I'm everything, the sympathetic says I'm this. And I can hold those apparently paradoxical poles at the same time. And I've got this singularity and focus and energy. So I like focus and energy. Freezy business is got everything, right? The whole range, nothing distinct in any of that. Right? Sympathetic says, yeah, I've got the whole thing, but I also have singleness of focus and also singleness of existence. So I can experience the distinction of reds and blues, and then the feeling of all of those together is me. And so if you get the oneness, you get the singleness, then you add the ventral vagal system, which is really unique for our species, and that's love. That's the warmth of caring and our social engagement, our existence as social beings and connected beings and tribal beings, which means that that I care as much for you as I do for myself, because we are together. And if I can do that within the framework of both singleness and within the understanding of everything together, we have something here. Because it seems to me the challenge of our movement is to be able to hold distinction, like the value of culture, and at the same time hold the larger frame of like the family of life. Certainly a human family, but also the family of life. If I can participate in all of that while not losing distinctness, then we've really got something. If I have the energy then to act effectively within that, I begin to manifest an input into the planet that I think is going to be A, enjoyable, fun, and B, more effective. So freezy business, gotta love it.